Hello. In part 2 of peripheral nervous system, I have explained all the 31 pairs of spinal nerves, okay, their nerve cores, then their functional aspect, the target organs these nerves are supplying, and various applied anatomical aspect also. I know it's a bit long session, but still I have covered all the 31 pairs of spinal nerves. Well, if you have any doubts or queries, please feel free to write to me, and hope you enjoy the session. In spinal nerves, you need to study about various branches, their distributions, and other functional aspects. And there are 31 pairs of spinal nerves. In these 31 pairs, we have a different plexus. What is the plexus? It's a union of group of nerves to derive one long important nerves. Okay, so as I told you, there are 31 pairs of spinal nerves. These spinal nerves are present in the right side of the body and also in the left side of the body. Okay, and these nerves are named according to the regional location. Okay, so for example, as I told you, there are 31 pairs of spinal nerves. Okay, we call them as cervical nerves. We call them as cervical nerves. This is the cervical nerve, and thoracic nerve, lumbar nerves, sacral nerves, and coccygeal nerve. Okay, so from C1 to C8, from C1 to C8, it is cervical nerve. But in cervical vertebra, you should have studied there are only 7 cervical vertebrae. Okay, but as far as nerves are concerned, there are 8 cervical nerves that are coming out and forming different other nerves we will discuss. Then there are 12 thoracic nerves. These nerves run on the intercostal space like this, and they supply the muscles in the intercostal region. Then L1 to L4, there are 5 lumbar nerves. Okay, L1 to L5, there are 5 lumbar nerves. Then 5 sacral nerves and 1 coccyx nerve Okay, so there are 8 cervical nerve, 12 thoracic nerve, 5 lumbar nerve, 5 sacral nerve, and 1 coccyx nerve. These are the names of the cervical nerves. The spinal nerves. But these nerves come out of the vertebral column and they form certain plexus. We will come back about the plexus. Okay, let's see how the nerve is coming out. Okay, if you see closely here, if you see closely in this region, you see this is a spinal cord, and this is one, and this is another nerve. This is the anterior root and this is the posterior root, and they come out in between each vertebra through the intervertebral foramen, and they form a ganglion here. Okay, from this ganglion there is posterior rami, that is posterior division. There is anterior division and one autonomic nerve, that is sympathetic nerve division. Okay, so you can see this in the next picture clearly. Okay, what you see here is, you see this is the cross section of the spinal cord. Okay, and this is anterior aspect and this is the posterior aspect. Okay, so from the anterior aspect there is a nerve that is coming out, and from the posterior aspect there is a nerve that is coming out. This fiber is called as preganglionic fiber, and this fiber is called as the postganglionic fiber. Okay, this is the This is the preganglionic fiber and this is the postganglionic fiber. Both these joins together to form a ganglion. Okay, ganglion is nothing but a collection of neuron cell bodies. It is a collection of neuron cell bodies. So anterior is the motor branch and posterior is the sensory branch. Okay, then after coming here, one division, it divides into three. One is the posterior rami and other is the anterior rami, and the next one is the sympathetic branch that forms the sympathetic ganglion adjacent to the body of each vertebra. Okay, and this is the intersympathetic root. This root is the intersympathetic root. That is one ganglion is connected by this ganglion by this intersympathetic root. Okay, so this is how the nerve output is dividing. Okay, this is how the nerve output is derived from the spinal cord. Okay, coming back, these nerves come out and form a plexus. What is a plexus? It's a union of group of nerves to derive some important nerves. Okay, so in that, from C1 to C4, C1 to C4, we have this cervical plexus. We have C1 to C4. There is, we call it as cervical plexus, and C5 to T1 is the brachial plexus, and there is no plexus from T2 to T12. Okay, so likewise from lumbar 1 to lumbar 4 we call it as lumbar plexus. Then L5 to S4 we call it as sacral plexus, and S5 coccygeal 1 nerve we call it as coccygeal plexus. Okay, so now we are going to see what all various plexus in details and their important nerves that is derived. Okay, you can see in this, you see there are C1 to C4. These four root come out and forms the cervical plexus. So the important nerves are the lesser occipital nerve, greater auricular nerve, and this is C1, C2, C3. They form one branch that is called as ansa cervicalis. We will discuss everything. This is the inferior root of ansa cervicalis and this is the superior root of ansa cervicalis. And the important nerve is this phrenic nerve that is having C3, C4, C5 root. Okay, and there is another supraclavicular nerve. We will discuss all these nerves one by one now. Okay, so let me open the other application to show you the important nerves. Okay, so keep in mind, from C1 to C4 we are going to discuss all the nerves that is derived. We are going to discuss all the nerves that is derived in this C1 to C4. Coming here, what you see here is this cervical root 1, and this is cervical root 2, then this is cervical nerve 3, and this is cervical nerve 4. Okay, these four nerves forms the cervical plexus. These four nerves forms the cervical plexus, and that's what we are going to see now. Okay, what you see here is, this is the cervical nerve 1, this is cervical, and this is the fourth cervical root. These four roots, they form the cervical plexus. Now we are going to see what are all the nerves that is derived in the cervical plexus. As I told you, if you see all the nerves here, it is more confusing to understand because the cranial nerves are coming down, the branches of this vagus nerve are coming in, so it's confusing. So what we'll do, we will arrange the muscle and we will see how these nerves are passing in between these muscles. Okay. Now, if you see here, the lesser occipital nerve that is derived from C2 nerve root, you can see this is the greater occipital nerve and this is the lesser third occipital nerve. So for that I am going to, this is the posterior paraspinal muscles. I will remove that. Okay. So what you see here is a suboccipital triangular. This is a suboccipital triangular space. From this, the suboccipital nerve is coming. Okay, the suboccipital nerve is coming, and this is the third occipital nerve, and this is the greater occipital nerve. Okay, so if you look at the origin path, if you look at the origin path of third occipital nerve, you see it is starting from C2 vertebra. Okay, here you have the C1 nerve and this is C2 nerve, and this is said to be a sensory nerve. Okay, these are all giving the sensory innervations to the scalp of the side of the head. Okay, now there is one greater auricular nerve, and this is the greater auricular nerve. This is the greater auricular nerve. This is from the C2 C3 nerve root. Okay, if you see the origin path of this greater auricular nerve, it is coming from the C2 C3 nerve branch. It is coming from the C2 C3 nerve branch, and you can see this nerve is the posterior rami. That is important. See, I have showed you where is the anterior rami and where is the posterior rami, and this is the posterior rami of the uh, cervical plexus, posterior rami of the cervical plexus. Okay, now we will go to the other nerves. We will go to the other nerves. So if you come down, I want to remove this anterior neck muscles, few anterior neck muscles. See, here you have the anterior triangle. This is the anterior triangle of the neck, and this is the posterior triangle of the neck. This is the posterior triangle of the neck. Triangle of the neck, we will discuss that separately in gross anatomy. I don't want to deviate into the other topics now. Okay, so I will remove the uh, this muscle, sternocleidomastoid muscle. Okay, now I am going to show you the ansa cervicalis. Okay, this ansa cervicalis is derived from the C1, C2, C3 nerve root. Okay, that this ansa cervicalis is supplying the muscle. Yeah, this is the ansa cervicalis. You see, you can see a nerve that is coming and forming a curve in the anterior triangle of the neck. That is coming and forming the curve in anterior triangle of the neck. Okay, so if you see here, there are transverse cervical nerve. This is transverse cervical nerve, and this is the inferior rami of the ansa cervicalis, and this is the superior rami of the ansa cervicalis. Okay, so inferior root and the superior root. So these these branches, they supply the muscles of the anterior neck. See, in the anterior aspect of the neck, there are homohyoid, there are a lot of small muscles. Okay, for example, this is the superior belly of the homohyoid muscle. Okay, so if you look at the innervation path, the superior ancestral, this is the homohyoid muscle, and this is a transverse cervical nerve. This is the transverse cervical nerve. Now we will, and here you have the inferior root of the ansa cervicalis. You have the inferior root of the ansa cervicalis. Okay, so I hope this is clear now. Okay, now what you see here is, I want to show you the supraclavicular nerve. Okay, this is the supraclavicular nerve, and you can see all the branches. Okay, so this supraclavicular nerve is innervating the muscles that is present in the supraclavicular region, and it is starting from C3 and C4 nerve root. C3 and C4 nerve root. Okay, but a very important nerve in this cervical plexus is the phrenic nerve. Okay, you know the phrenic nerve, it is supplying the diaphragm. The phrenic nerve is supplying the diaphragm. So for that I want to show you the phrenic nerve. Okay, so I have to remove certain muscles. Okay, so instead I will catch the I have to show you the diaphragm. Diaphragm is a muscle that is present between the abdomen and the thoracic cavity. Okay, okay, here you have the diaphragm. This is the respiratory diaphragm. Okay, if you look at the innervations, okay, see, this is the phrenic nerve. You see, the phrenic nerve starts in C3, C4, C5 branch. This is 3, this is 4, and this is 5. Okay, this is 3, 4, and 5 branch. And this nerve is coming all the way down, and you can see how the nerve is spreading on the diaphragm is. Okay, how the nerve is spreading on the diaphragm like this. Okay, so this is the right dome of the diaphragm, and this is the left dome of the diaphragm. In the right dome, you can see the nerve comes and spreads all over the diaphragm, and thereby the diaphragm is contracting during the time of respiration. During the time of respiration. Okay, this phrenic nerve is passing through the mediastinum. This phrenic nerve is passing through the mediastinum by the side of the heart. Okay, it is curving in the lateral, I mean the lateral aspect of right heart and the left heart, and then it is supplying the diaphragm. And very important thing is about the clinic, there is fracture of cervical vertebra at C6 level, the breathing will not be affected. Whereas if there is fracture of cervical vertebra at C2, C3 level, then there are chances for diaphragm paralysis. If the diaphragm is paralyzed, the person is not going to breathe. Okay. Likewise, you would have heard about ascending paralysis. You would have heard about ascending paralysis. Ascending paralysis is the spinal cord. There is anterior horn cell and posterior horn cell, which gives anterior motor fiber and posterior sensory fiber. So there are diseases which affects this anterior horn cell. For example, Guillain-Barré syndrome, poliomyelitis. Okay. So what happens? This damage of anterior horn cells starts at the lower level of the spinal cord, and it gradually keeps moving. So when the damage is up to thoracic vertebra, there will be paralysis of both the leg. But still, if the damage is progressing, then there is damage of the four limbs, brachial plexus and quadriplegia will be there. Still, if the lesion is progressing up, it can reach to C3, C4 level. When the damage reaches C3, C4 level, this level, then what happens? Even the diaphragm also gets paralyzed. So those type of patients, we need to link the patient to the ventilator machine. Otherwise, they cannot breathe. Otherwise, they cannot breathe. Okay. So this is a ascending. This is very crucial in ascending type of paralysis like Guillain-Barré syndrome, or let's not go into pathology now. So please know the importance of phrenic nerve. Okay, fine. So now we will go into the brachial plexus. Coming to this brachial plexus, what you see here is the nerve that is coming from C5, C6, C7, C8 and T1, the brachial plexus nerves. Okay, these nerves comes out, this nerve comes out and forms the different main branches of the nerves. So we will discuss each and every branch accordingly. So what you see here is uh, you can see this is a C5 nerve root, C6 nerve root, C7 nerve root, C8 nerve root and T1 nerve root. Okay, so this is the root level. This is the root level. Okay, so in the root level, it forms the trunk. From the trunk, it forms the cord. Okay, from the cord, there are three cords: lateral cord, posterior cord, and the medial cord. From the cord, there are important nerves that is derived, and these nerves going to the upper limb. Okay, it is supplying the upper limb area. So we will discuss each and every nerve. Okay, so before that, you have to know the anatomical location of the brachial plexus. You have to know the anatomical location of the brachial plexus. For example, in the neck, okay, there is something called Scalene Triangle. So I'm going to show you the Scalene triangles. That is a triangle that is formed by these muscles that is present in the lateral aspect of the neck. Okay, so through the triangle, these nerves are derived, and then this cord, I mean this trunk is running in the posterior aspect of the clavicle. So it's better we see in the 3D model so that you will have a better understanding. What you see here is the muscles of the anterior neck. Okay, and this is anterior scalene muscle, and this is his posterior scalene muscle. Sorry, this is a posterior scalene muscle, and this is a medial scalene muscles. Okay, and this triangle is called as a Scalene triangle. This triangle is called as the Scalene triangle. Okay, so what you want, I want to arrange the nerves and the neurovascular structures. In fact, see one artery. This is the subclavian artery that is passing through this Scalene triangle. Okay, but the vein is not passing through this Scalene triangle. Subclavian vein is not passing through this Scalene triangle. Okay, so we will look into. Then if you look at the nervous structure, if you look at the nerves, okay, so what you see here is these are the brachial plexus nerves. Okay, and this is one subclavian artery. These both these neurovascular structures exiting out through this Scalene triangle, and this is the root level. This is the root level. Okay, then you have the trunk level in the posterior aspect of the clavicle. Okay, this is the anterior curve of the clavicle. Okay, this is the medial 1/3 curved anteriorly of the clavicle, and in the posterior aspect of the curve, these are the trunk level of the brachial plexus. Imagine when there is a fracture of the clavicle, it damages the brachial plexus at the trunk level. Okay, this is what you have to understand. So, and if there is any damage to the subclavian artery, then the situation is different. Okay, there will be hematoma formation, all this stuff. So in brachial plexus injury, you have to know at which level the nerves are getting damaged. Then from the clavicle, the post aspect of in the axillary region, the cords are present. The cords of the brachial plexus are present. So here there is one axillary sheath that is made by connective tissue. Okay, this is called as clavipectoral fascia. Okay, this one. Okay, see, you can appreciate a tubular sheath. You can appreciate a tubular sheath. Okay, so this sheath is very important to give brachial plexus block. Okay, suppose if there is any surgery the patient is undergoing in the forearm, then giving general anesthesia is generally not advised. So we have to trace this sheath. Okay, this is called as axillary sheath. This is called as axillary sheath, and you can see the nerves and the blood vessels are running through this axillary sheath. The nerve, blood. Let me select the other nerve. Okay, you can see the nerves that is passing in the axillary sheath. So this sheath is a connective tissue sheath. You have to locate this sheath by palpating the pulse of this artery. Okay, for example, you have, this nerve is in relationship with the axillary artery. Okay, the cord level of the brachial plexus is in relationship with the uh, axillary artery. So what you have to do whenever you give axillary block, you have to first palpate the axillary artery, keep a finger on the axillary artery, and insert the needle adjacent to your finger. Okay, suppose if the patient feels electric sensation, it means you are pricking the nerves. Okay, then you need to remove it immediately. Okay, then when the needle goes certain depth adjacent to this artery, then you can inject this xylocaine, which is a nerve blocking agent, to anesthetize this upper limb. Okay, to block the painful sensation of the upper limb. Okay, so this is the importance of axillary sheath. Now you can see. Okay, now you can clearly appreciate how the axillary sheath is enclosing the but the vein, if you see the vein, okay, this deep vein is passing in the axillary sheath, whereas the superficial vein, that is a cephalic vein, is joined deep vein here. Okay, so this is the clinical importance you have done. That I will teach you when I'm teaching the branches of vessels in the circulatory system. All right, so just have a rough idea how this neurovascular structure is arranged in this region. Okay, so now you know the root level, you know the trunk level, and you know the cord level. Okay, the root level is present in this before the scalene triangle. The trunk level is present between from the scalene triangle and the post aspect of the clavicle, and the cord level is present in the axillary region. This is the axillary region. And now what we will do is, from the root level we will trace out different nerve branches and its muscle supplies. Okay, we will trace out different nerve branches and this one. So one is the, as I told you, there are posterior rami as well as the anterior rami. That is the post. I will turn the body to a posterior side. Okay, so you have this long thoracic nerve. This is the, sorry, this is the accessory nerve. I will remove it. Okay, this is the dorsal scapular nerve. Okay, this dorsal scapular nerve is a C5 nerve root. Okay, if you look at this, it is coming from the cervical 5. Okay, this is the cervical nerve 5 nerve root, and this is supplying the muscles of the interscapular region like rhomboids major, rhomboids minor, and all this stuff. Okay, then this is one branch, that is a posterior rami. Then you have this intercostal nerve and the long thoracic nerve. Okay, this is the supraclavicular nerve that is starting in the cord level, sorry, trunk level. I will remove these muscles to explore those nerves. Yes, what you see here is a long thoracic nerve, posterior branch. This is a posterior branch. Okay, okay. What you see, this is a posterior branch of the long thoracic nerve. So what you see here is this long thoracic nerve is from C5, C6, and C7 nerve root. Okay, and it is coming in the lateral aspect and supplying the serratus anterior. So these nerves are from the root level. These nerves are from the root level. Now what we will do is, we will go to the trunk level. Okay, as you know, you have to observe this how the root is forming the trunk. How the root is forming the trunk. If you go to this picture, okay, you see this is C5, C6. Okay, the C5, C6 forms the root, and this C7 is not, you have to just look carefully. C5, C6 is joining together, C7 is not joining together, it is coming separately. Then C8 and the T1 nerve root are joining together. Okay, these are the chord level. And this C5 and C6 forms the superior trunk. Then C7 forms the middle trunk, and C8 and T1 forms the inferior trunk. So this is superior trunk, middle trunk, and the inferior trunk. Okay. So then how the cord is formed? As I told you, the superior cord is coming and dividing into two branch. I will remove the clavicle here. The superior cord is coming and dividing into two. This is the lateral cord. Okay. Then the middle trunk gives a nerve and joins with the lateral cord. Okay. And here you have the posterior cord and the medial cord. This is the lateral cord, posterior cord, and the medial cord. Okay, medial cord you have two branches. So this is the medial cord, and this is the posterior cord. So this is the posterior cord, and this is a lateral cord. Lateral cord, posterior cord, and the medial cord. So this is the medial cord. Okay. Then this is a superior trunk, middle trunk, and the inferior trunk. Okay, and this is a C5, C6 nerve to C8, C8 and T1 nerve. So now this root level, trunk level, and the cord level. Okay, so now you see the location of the clavicle, and if there is any damage, the damage is more prone at the trunk level. Okay, if there is any damage in the axilla, then there is more the damage is prone in the cord level. Okay, this is what you have to understand. So now if you I will arrange a few muscles so that it will give you a clear landmark. It will give you a clear landmark of to understand the brachial plexus. All right. So now we have seen the roots, that is branches that is coming from the cord level in this level. That is the dorsal scapular nerve, then the long thoracic nerve, and in the posterior side you have there are nerve to longus musculi, scalene muscle, and all this stuff. Okay, these are all these small fine branches. Then at the trunk level, imagine I have told you this is the level of the trunk. Okay, this is the level of the trunk. There is one nerve that's called the suprascapular nerve. Okay, so what I have to do, I have to remove the muscles, supraspinatus muscle, and here you have the suprascapular nerve. Okay, so if you look at the suprascapular nerve, this nerve is starting in the trunk level. This nerve is starting in the trunk level, and it is going all the way in the posterior suprascapular. This is the suprascapular notch, and there is also one suprascapular artery. This artery and the nerves are friends. Wherever the arteries are going, like the nerve also try to travel with them. The nerve also try to travel with them. You see, this is the suprascapular artery, and this is a suprascapular nerve. There is a notch here. Through this notch, they come and they supply the supraspinatus muscle in here. They are supplying the supraspinatus muscle in this region. Okay, so now we will go back. And then okay, so this is the only nerve, that is suprascapular nerve, that is originating in this trunk level, which is having C5 C6 nerve root. Okay, which is having the C5 C6 nerve root. Now let's move to the cord level in this area. Okay, let's move to the cord level. I have shown you various cards. In here. Okay, so what you see here is the I'm placing the artery because in order to show you the difference. Okay. Now I will remove this artery, and it's better because it is okay. This is the lateral cord. This is the posterior cord, and this is the medial cord. Okay, lateral cord, posterior cord, and the medial cord. And you see how the artery is running now. Okay, see, the axillary artery is running around this. I mean, these cords are running around the axillary artery. Okay, these cords are running around the axillary artery, and that's why we palpate this. We ask the patient to keep the arm in abducted position, palpate this artery, and then insert the needle by the side of the artery so that it goes directly into the axillary sheath, and the xylem is filled around the nerve, and the nerve gets blocked. Okay, now in the cord level, from the cord only the main branches nerves, all these nerves that you see, the musculocutaneous, axillary, radial, median, ulnar nerves are derived from this cord. Okay, so if you see here, in the cord level there are few nerves. One is the lateral pectoral nerve. Okay, so I will show you the lateral pectoral nerve. So this is the lateral pectoral nerve. This is the lateral pectoral nerve, and it is supplying the pectoralis major muscle. Okay, so if you see the muscle here, this is the pectoralis major muscle, and if you look at the nerve supply, this is the lateral pectoral nerve. This is the lateral pectoral nerve. Okay, and this nerve is derived at the cord level. Okay, and it is supplying this. Okay, is major, that is present in the anterior aspect of the chest. That is present in the anterior aspect of the chest. You can see from the posterior side how the lateral, I mean the pectoralis major, is getting the nerve innervation. Okay, and it is also supplied by the few branches of the medial pectoral nerve. But know that the important nerve is the lateral pectoral nerve. The important nerve is the lateral pectoral nerve, that is present in the cord level. It is present in the cord level. Okay. Next, we will go. This lateral pectoral nerve is from the lateral cord. This lateral pectoral nerve is from the lateral cord, and now from the posterior cord. So I will show you. Okay. This is the lateral cord, and this is the posterior cord. From the posterior cord, you have three nerves. One is the upper subscapular nerve, thoracodorsal nerve, and the lower subscapular nerve. Okay. So this subscapular nerve is innervating the subscapularis muscle. Okay. So this is the upper and the lower subscapular nerve. Okay, and this is the subscapularis muscle. This is the subscapularis muscle, you can see, and this is the posterior cord, and the subscapular nerve is starting in the posterior cord level. In the posterior cord level. Okay, in the posterior cord level. Next, you have the thoracodorsal nerve. Okay, this thoracodorsal nerve is supplying the latissimus dorsi muscle. Okay, is supplying the latissimus dorsi muscle. Okay, here you see, this is the posterior cord, and from the posterior cord the thoracodorsal nerve is coming, which is having the nerve root of C6, C7, C8. See, C6, 7, 8. From all these nerves, the neurons are coming, and then it is supplying this this one, and this latissimus dorsi muscle, which is the largest flat muscle in the human body. You see, these nerves are getting down in the lateral aspect, and this is one of the climbing muscles. In myology, we will see that. Okay, then in medial cord, let's go to the next nerve. In the medial cord, you have this medial pectoral nerve, medial cutaneous nerve, brachial cutaneous nerve, and medial antebrachial cutaneous nerve. Okay, these are the nerve that is supplying the skin region. These are the nerve that is supplying the skin region. So this is how you are going to understand this brachial plexus nerve from the cord level. Okay, now the important nerve that is derived from the brachial plexus are axillary nerve, musculocutaneous nerve, radial nerve, median nerve, ulnar nerve. Okay, now what we will do, we will catch each and every nerve and trace their locations and their muscle supply. Okay, so for your simple understanding, upper limb, the muscles of the axillary shoulder region are supplied by the axillary nerve, and the muscles of the anterior arm is supplied by the musculocutaneous nerve. The muscles of the anterior forearm is forearm and the hand is supplied by the ulnar and median nerve. Median nerve in the medial side and ulnar nerve in the lateral side. Okay. Then muscles of the posterior arm and forearm are supplied by the radial nerve. The radial nerve is the longest nerve in the upper limb. Okay, we will trace that nerve and in which location it is passing. First, we will start with the axillary nerve. Okay, this axillary nerve is having the nerve root of 6. Okay, I told you the muscles of the okay, this is muscles of the shoulder region. It is supplying the muscles of the shoulder region. So when you look at the axillary nerve, this axillary nerve is coiling the surgical neck of the humerus, okay, along with the axillary artery. Okay, you can see this is the circumflex humeral artery. Okay, this is circumflex humeral artery, and this is the axillary nerve. Okay, both these structures are coiling the surgical neck of the humerus. So whenever you give intramuscular injection in the deltoid muscle, okay, this is the location of the deltoid muscle. So whenever you give intramuscular injection of the deltoid muscle, those two structures, that is the circular artery as well as the axillary nerve, prone for damage You see, this axillary nerve. Okay, so if you look at these branches, it is originating in C5 C6 nerve root, and you see it is derived from the lateral cord. Okay, it is derived from the posterior cord, and it is coming and coiling the surgical neck of the humerus. Okay, supplying the deltoid muscle. Next, we will go to the musculocutaneous nerve. As I told you, all the muscles that is present in the anterior aspect of the arm, like biceps, then inside this brachialis, okay, coracobrachialis, and all these muscles are innervated by the musculocutaneous nerve. You can see the musculocutaneous nerve, and is passing. It is coming all the way to the axilla. From the axilla, in the lateral cord, it is the branch is starting, and it is coming all the way between the brachialis and the biceps muscle. And this is how the anterior muscles of the arms are supplied by the musculocutaneous nerve. are supplied by the musculocutaneous nerve. Okay, next we will go into the radial. Okay, let's finish the muscles of the anterior side. Okay, then we'll go for the radial nerve and median nerve. Okay, this median nerve is derived from C5, C6, C7, C8 and T1 nerve root. The branch and the medial cord. Okay, so what you see here is okay, okay, this is the median nerve. This is the median nerve, and I will show you the branches. Okay, you see the median nerve is coming in the medial aspect of the arm. The median nerve is coming in the medial aspect of the arm, and it is crossing in the anterior cubital fossa. This is the anterior cubital fossa. The pit in the anterior aspect of the elbow is called as the anterior cubital fossa. You can see here, this is the anterior cubital fossa. Okay, so in the inside this fossa, the median nerve is coming in the medial side. The median nerve is coming in the medial side. Then branches start to see the muscle of the anterior. In the anterior forearm, this is the medial side and this is the lateral side. So whatever muscles present in the anterior aspect of the medial side, all these muscles are doing the flexor movement that we discussed it in the myology. Okay, so if you see here, the nerve muscles that is present in the medial side of the arm are innervated by this median nerve. Okay, and it is going in the anterior aspect of the interosseous membrane. Okay, if you see the interosseous membrane between this two bone, okay, the radius and ulna bone, this nerve is passing in the anterior aspect of the interosseous membrane and comes all the way and enters into the flexor retinaculum. So this is the flexor retinaculum. This is flexor retinaculum, the carpal bones, and this is a flexor retinaculum, also called as transverse carpal ligament. And this nerve is entering inside this tunnel. We call it as a carpal tunnel. This is called as a carpal tunnel. So when you can see the muscles also in this region. Okay, you can see the muscles also in this region. Okay, so this is the median nerve, and the median nerve is branching into the palmar digital nerve. Okay, so the first 3.5 finger areas, this is thumb, index, middle. This is the thumb, this is index, and this is the middle, and this is a ring finger. Okay, so the anterior 3.5 finger area muscles and spines are innervated by the median nerve. So this median nerve is supplying the thenar muscles, then the first, second and third palmar and the interosseous lumbricals and the palmar interosseous muscles. Okay, lumbricals and the palmar interosseous muscle. So for example, if you see the nerve supply of this, it's a median nerve. It is the okay, see the median nerve is coming all the way, and this is a carpal tunnel entering into the carpal tunnel. The carpal tunnel syndrome is very famous. When there is compression of this transverse carpal ligament during support of the hand keeping the keyboard, the nerve gets compressed, or if there is no more encroachment of the fats in this carpal tunnel, then there is nerve compression, and then there is radiating pain in the first 3.5 fingers in the anterior aspect of the arm. So that's what we call it as carpal tunnel syndrome. Okay, so it's very simple. Suppose if the C5 nerve root press, for example, the C5 nerve root is present in this area, the C nerve root is present in this area. So if this nerve root is compressed here, all the way where the median nerve is going, there will be radiating pain. The patient will keep complaining of radiating pain in all these areas. Okay, that's the specialty of the nerve. So never touch the nerve. Okay, it will give you a lot of trouble. Okay, so now you understand the distribution of the median nerve. Now we understood the distribution of median nerve. Next, into the ulnar nerve. Okay, you know what? This ulnar nerve is passing. I will show you. The medial aspect. Okay, this is the ulnar nerve. Okay, you know the ulnar nerve is having the nerve root of C7, C8, and T1. Ulnar nerve is having the nerve root of C7, C8, and T1. As I told you, this ulnar nerve is passing all the way. Okay, here. Okay, it is passing all the way. It is starting from the medial cord. This is the medial cord, and it is passing through the axilla, and it is passing through the. Let me remove the muscles and show you. Okay, so this is the ulnar nerve. Okay, if you see here, the ulnar nerve is starting in the medial cord, and it is passing in the medial aspect, and in the level of the elbow, this is a medial epicondyle. This is the medial epicondyle. So when you palpate in the posterior aspect of the medial epicondyle, you can feel a nerve structure. So this nerve is more superficial, only skin is present here. Okay, so what happens sometimes when you hit the elbow in the chair or in the table, you feel some electric shock sensation in the forearm. That is happening due to the location of the ulnar nerve more superficial, the posterior aspect of the medial the humerus. This is the medial epicondyle of the humerus. This is the medial epicondyle of the humerus, and this ulnar nerve is passing just in the posterior aspect of the humerus. So patients who are having who are suffering with leprosy, mycobacterium leprae, we feel the thickening of the peripheral nerves by palpating this ulnar nerve in the medial aspect of the medial condyle, medial epicondyle. Okay, in the posterior aspect of the medial epicondyle, if you feel a thickened nerve, then you can by various investigations you can know, clinically diagnose the patient is suffering with mycobacterium leprae, in which the peripheral nerve starts to become thick. Okay, there will be thickening of peripheral nerves. Okay, so this ulnar nerve is passing the medial aspect, and then at the level of elbow, sorry, wrist, and it is supplying the lateral 1.5 finger, that is the little finger and the ring finger, the little finger and the ring finger. That's the speciality. So the palmar introsi and the lumbrical muscle present in the little finger and the ring finger areas are innervated by this ulnar nerve. So the ulnar nerve is having the nerve root of C7, C8, and T1 level. Okay. Then let's go to the longest cranial nerve, that is the radial nerve, which is having the nerve root from C5, C6, C7, C8, T1, and this radial nerve is mainly derived from the posterior cord. Okay, this is the posterior cord. This is this is the this is the posterior cord of the brachial plexus, and the main nerve that is derived from the posterior cord is the radial nerve. This is the radial nerve. Okay, so what you see here is the radial nerve. This radial nerve is exiting from the axillary sheath, and it is passing the posterior aspect of the humerus. Okay, in the bone, if you see, this groove is called as the spiral groove. This groove is called as the spiral groove or the radial groove. So in this radial groove or spiral groove, the nerve is passing in the posterior aspect of the humerus. The nerve is passing in the posterior aspect of the humerus. Happens, uh, supports a hand in the window of a train or some desk, whatever, continuously for more than 1.5 hours. This nerve is prone for long time compression, and it leads to paralysis of the extensor muscles of the forearm that leads to wrist drop. We call that condition as Saturday night palsy. Why palsy means paralysis? Why it is taking place in the Saturday night? Saturday night is weekend, and people used to have alcohol, booze too much, and they travel by supporting the arm in the window or something like that, where the nerve gets compressed. So they cannot extend the wrist. Then they will see what is happening to my hand. Then it happened due to compression of the radial nerve. Okay, so the treatment has to be given by nerve stimulation, muscle stimulation, all this stuff. So that condition is called as Saturday night palsy. You can Google it. Okay, let me not deviate to the pathology. So you just understand the radial nerve is passing in the posterior aspect of the humerus, that is in the spiral groove or the radial. In the lateral aspect, it is traveling in the lateral area. It is traveling in the lateral area. And now, if you look at these branches, you see this nerve is passing all the way to the posterior aspect, and it is supplying the muscles that is present in the posterior aspect of the forearm. Okay, this nerve is also supplying the muscles of the posterior aspect of the arm, the triceps and coneus. Or so now you have all the extensor muscles. You have all the extensor muscles. Okay, so you can see all the extensor muscles have the common origin of the lateral epicondyle. So these are all the extensor muscles, and all these extensor muscles are innervated by the radial nerve, or innervated by the radial branch of the radial nerve. Okay, this is a branch of the radial nerve that is supplying the muscles of the, and also the cutaneous supply. The cutaneous innervation is also by the uh, okay. You see, as I told you, the radial nerve is having C5, C7, C8, and uh, uh, okay, these are all the radial nerve innervation. Okay, so we will discuss about the dermatome innervation separately in the last slide. Okay, posterior arm, forearm, and the skin is supplied by the radial nerve. Okay, then the muscles of the anterior arm is supplied by the musculocutaneous nerve. This 1.5 finger is supplied by the ulnar nerve, and the 3.5, that is thumb, index, middle, and half of the ring finger is supplied by the median nerve. So the speciality here is the 3.5 fingers is innervated by, the ring finger is innervated by 3 nerves: the ulnar nerve, median nerve, and also the radial nerve. Okay, that is the specialty of the ring finger. The ring finger receives the sensory innervation by 3 nerves, that is ulnar nerve, median nerve, and the radial nerve. So these are nerves that derived from the brachial plexus. These are the nerves that is derived from the brachial plexus. So keep in mind, guys, the musculocutaneous nerve C5, C6, C7, the axillary nerve C5, C6, radial nerve C5, 6, 7, 8, and T1, median nerve 5, 6, 7, 8, and T1, and the ulnar nerve C7, C8, and T1. These are all the important nerves derived from the brachial plexus, that is supplying the muscles of the upper limb and also the trunk region and the interscapular muscles. Okay, so pathology the applied anatomy we will discuss that as a separate topic. So just focus in anatomical nerve innervation in this step. Okay. Coming to the applied anatomical aspect of brachial plexus injury, there are many chances for brachial plexus injuries during the road traffic accidents or fall with outstretched hands where this clavicle gets fractured and it can damage the brachial plexus nerves that is present in the posterior aspect of the clavicle. And during the time of birth, when the child is stuck in the birth canal, so the person who conducts labor and delivery who will have to pull the head out, okay, when during forceps delivery or during manual presentation. So that time there are chances for C5 C6 nerve root to be. Okay, this is what we call it as Erb's palsy. We call this condition as Erb's palsy, where the hand will, the upper limb will go in for medial rotation. Okay, and we call it as fingertips deformity. We call it as fingertips deformity, that is damage to the C5 C6 nerve root, which we call it as Erb's palsy. So this can be diagnosed like when the child reduces the movement in this affected upper limb and the child keeps the hand, the upper limb internal rotated. Okay, so this is called as Erb's palsy. And next one is the Klumpke's palsy. So this is damage of the C8 T1 nerve root. Okay, when there is damage, same pulling effect of the C8 and T1 nerve root, it leads to a condition called Klumpke's palsy, where there is claw hand formation. Okay, the muscles of the extensors doesn't work and it leads to claw hand. And moreover, the T1 nerve root is also affected, which is giving an autonomic ganglion, that is the OT ganglion, that is supplying the iris. So this is leading to Horner syndrome. There is something called Horner syndrome. You can Google it. So these are all the effects of this brachial plexus injuries. Okay, so this Erb's palsy and Klumpke's palsy are common in the time during the time of birth. It's not very common. There are chances. Okay. Moreover, there are another thing called thoracic outlet syndrome. Okay, so what you see in this picture is this scalene triangle. Okay, through which the brachial plexus nerves are coming out. The subclavian artery. Okay, and this is the first rib, and above the first rib you have the location of this clavicle. So what happens when this clavicle presses the nerve root against the first rib? It leads to radiating pain. It leads to radiating pain in the upper limb. This is what we call it as thoracic outlet syndrome. Okay, so likewise there are many applied anatomical aspect we can discuss, like Saturday night palsy in case of radial nerve compression, where there is wrist drop. Then when there is ulnar nerve injury, it leads to partial claw hand. The last little and the ring finger paralyze with flexion of the fingers. We call it as partial claw hand. And when there is median nerve injuries due to accidents or it leads to claw hand. Okay, the first thumb, index, and the middle finger will go in for paralysis. Okay, so that leads to claw hand. And moreover, If there is a nerve compression at the wrist level of the median nerve, it leads to a radiating pain in the hand. It's called as a carpal tunnel syndrome, which I would have explained you before. Okay, so next we have to go into the thoracic nerves. Okay, there are 12 thoracic nerves: T1, T2, T3, T4, T5, C6, T7, T8, T9, T11, T12. Okay, as we all very well know that these thoracic nerves are passing in the intercostal space and they form any plexus, except they give this sympathetic ganglion that we will discuss in the autonomic nervous system, how the sympathetic ganglion is derived from the thoracolumbar nerves and what are the branches that is giving, we will discuss in the autonomic nervous system. Okay, so if you look at the previous pictures, so what you see here is the thoracic nerves. Okay, so these are the intercostal space, these are the intercostal space, these are the intercostal space where you have the location of intercostal muscles, and the thoracic nerves originate from the thoracic spinal cord, and it is passing all the way in the intercostal space like this. Okay, moreover there are some clinical aspects that you have to understand. I will do now. So this is the place where the location of intercostal nerve is present, that is supplying the intercostal muscles. Okay, moreover, if you look at this intercostal nerve, it is passing through the costal groove. So let me show you, because this is clinically it's very important for you. The thoracic nerves, as I told you, it starts from T1 to T12, and this is located in the rib cage level. This is located in the rib cage level. So rib cage, yes, this is a rib cage, and you have 12 thoracic vertebrae. You have around 12 thoracic vertebrae in the posterior aspect, and you have the sternum in the anterior aspect, and these are the 12 pairs of ribs, and these ribs are connected to the sternum by the costal cartilage. This is the costal cartilage. Okay, so in between you see, now I will remove all this ribs. Okay, so here what you see here is the T1 nerve root. This is T1 nerve root. This is T2 nerve root, T3 nerve root, T4 nerve root, T5 nerve root, T6, T7, T8, T9, T10, T11, T11 nerve root, and the T12 nerve root. Okay, these are the T12 nerve. Okay, if you see these nerves, they originate in the vertebral level and they come and innervate in between the ribs. So if you see the ribs now, okay, so here you see they are passing through in the intercostal space. Okay, so if you see a single rib, if you see, you can see a pit like structure that is called as a costal groove, that is called as the costal groove, and this is the place where the vein is running. Vein is vein, artery, and the nerve. Okay, so you can see this is the intercostal artery and this is the intercostal vein. Okay, so what I will do, I will remove this in the posterior side. I will remove it in the posterior side. Okay, so what you see here is the intercostal nerve, intercostal vein, and the intercostal artery. Okay, so all you have to understand here is it is running in the costal groove in the inferior aspect. So there are some situations that arises where you have to give puncture the thoracic cage and drain the fluid when there is intrapleural fluid accumulation. You need to insert the tube so that time you have to select the upper border of the costal margin, not the lower. If you are selecting the lower margin, you are prone to damage this intercostal nerve. So you always have to select the upper border of the ribs so that you preserve these neurovascular structures in the lower border. You preserve these neurovascular structures in the lower border. Okay, so this is the clinical point that you have to understand in the intercostal nerves. Okay, so these nerves are supplying the muscles in between the ribs, the intercostal muscles, and also it is giving the cutaneous branch. It is also giving the cutaneous branch, anterior cutaneous branch, and the posterior cutaneous branch. Okay, so now these are the 12 nerves, the 12 thoracic nerves. Okay, but these thoracic nerves, they mainly form they mainly form the sympathetic ganglion. They mainly form the sympathetic ganglion. If you see here, um, okay, wait, okay, these are the sympathetic ganglion. These are the sympathetic ganglion. You can see it is present all the way. Okay, and these are the intersympathetic fibers. These are the sympathetic fibers. Okay, so if you isolate this and see, okay, this is how the sympathetic chains are formed from the thoracic nerves. See, this sympathetic chain is present in uh, thoracic nerves as well as the lumbar nerves. Okay, that we will see uh, in depth in this autonomic nervous system. Okay, that we will see in depth in the autonomic nervous system. And these are all the intersympathetic fibers, ganglion fibers. Okay, and these sympathetic ganglions, they transmit the pain impulse to the brain. Okay, so that's why in chronic cancer patients, they do this intersympathetic ganglionectomy. Okay, so they cut this fiber so that the pain impulse is not taken to the brain. Okay, so that we will see that in a simple autonomic nervous system. Coming to the lumbar plexus, lumbar plexus starts from L1, L2, L3, and L4. These are all the lumbar plexus nerve root. Okay, so if you see here, this is a lumbar 1 vertebra, L2 vertebra. This is L1, L2, L3, and L4. If you see the nerves, if you observe the nerves closely in between, let me go in the posterior aspect. Let me go in the posterior aspect. If you see here, this is the first lumbar nerve, and this is the second lumbar nerve, and this is the third lumbar nerve root, and this is the fourth lumbar nerve root. Okay, 1, 2, 3, and 4. Okay, these are the 4 lumbar nerve root. These 4 nerve root forms the lumbar plexus. So if you look at the important nerves of the lumbar plexus, it starts with the ilioinguinal and the iliohypogastric nerves. Okay, these are the sensory nerves. In fact, in L1, these are the two ilio. Okay, this is the ilioinguinal and this is the iliohypogastric nerves. Okay, this is the iliohypogastric nerves. So what happens here? These nerves, they originate in the L1 nerve root and they pass through the quadratus lumborum muscle and they travel through the iliac crest. Okay, and in the anterior aspect of the abdomen, they travel on the inguinal ligament. This is the inguinal ligament. This is the inguinal ligament. Okay, and this is the inguinal ligament. Okay, now what you see? This is the ilioinguinal and iliohypogastric nerve. They pass through the inguinal ligament and they supply the areas of perineum, both in male and female. So during the time of hernia repair, when the surgeon makes incision, this nerve is prone for damage and the patient feels some numbness in the pubic region. Okay, so that is impossible. You have to preserve this ilioinguinal and iliohypogastric nerves in this region. Okay, ilioinguinal and iliohypogastric nerves in this region. Okay, so these are the two nerves. Okay, these are the two nerves that is coming in the anterior aspect of the thigh, anterior aspect of the inguinal region. Okay, so this is said to be the sensory nerve. This is said to be the sensory nerve. This is said to be the sensory nerve, and you can see how it is running in the anterior aspect of the inguinal region. Okay, next nerve is the genitofemoral nerve. Next nerve is the genitofemoral nerve. Okay, so this is the genitofemoral nerve and it is giving the cutaneous innervation. It is giving the cutaneous innervation. Okay, let me keep some muscles. Okay, you see this genitofemoral nerve is running on the iliopsoas muscle and it is passing inside the inguinal ligament and it is distributing the sensory nerve fibers to the anterior aspect of the thigh. It is distributing the sensory nerve fibers to the anterior aspect of the thigh. So this is having the nerve root of L2. Okay, then this is the lateral femoral cutaneous nerve of the thigh. This is the lateral femoral cutaneous nerve of the thigh, and this is also responsible for lateral thigh cutaneous distribution. Okay, it is also starting in the L2 nerve root. Okay, it is also starting in the L2 nerve root, and it is distributed to the lateral aspect of the thigh. Okay, so next the important nerve is this femoral nerve. The important nerve is this femoral nerve. Okay, so if you look at the femoral nerve, this femoral nerve is having motor fibers as well as sensory fibers. The motor fibers is supplying the anterior thigh muscles. Okay, in the anterior aspect of thigh, you have this quadriceps muscle. You have this quadriceps muscle. Okay, these are the anterior the rectus femoris, vastus medialis, then vastus lateralis, and vastus intermedius inside, and also the sartorius. All these anterior thigh muscles are innervated by the femoral nerve, and the cutaneous sensation is done of the medial aspect of the leg is by this sensory branch of the femoral nerve. Okay, so now what you have to understand is this nerve course. You have to understand is this nerve course. So what you see here is the inguinal ligament. What you see is the inguinal ligament. Okay, so if you see there is an inguinal canal, where the vein is running. So okay, this is the femoral vein. This is a femoral artery. This is a femoral artery, and this is a femoral nerve. Okay, so VAN. Okay, femoral vein, femoral artery, and femoral nerve. So you have to what you have to understand here is this is anterior superior iliac spine, and this is the pubic tubercle. So you place the finger on the inguinal ligament in the middle of this anterior superior iliac spine and the pubic tubercle. You can feel the pulse of the femoral artery. You can feel the pulse of the femoral artery. So once you place the finger here, once you place the finger here, for example, once you place the finger here, and insert the needle in the medial aspect of the pulse. You enter into a femoral vein where you can get the blood sample for analysis or whatever it is. Okay. Whereas in pulse, you will enter into the femoral artery, where you can take blood samples for blood gas analysis. You need arterial blood, isn't it? So that time you can. But the nerve is present in the lateral aspect. The vein is present in the medial aspect. This is important thing I understand, because there are obese patients where you don't get vein access during the time of emergency. Okay, so it is very important anatomy you need to hear. You need to know here. Okay, next we see, we will go to the next nerve. That's the obturator nerve. This is also from the lumbar plexus. Okay, this is also from the lumbar plexus. I will remove this vein and the artery. Okay, this foramen, what you see here is the largest pubic ramus, inferior pubic ramus, and the ischial ramus. And there is a membrane here called as the obturator membrane. This membrane is present. It gives little bit of place for musculogen insertion with the obturator, internus, and the externus muscle. Okay, so if you observe here carefully, there is a small canal that's called the obturator canal. So through which the obturator nerve is passing, plus the obturator artery. This is the obturator artery. Yeah, this is obturator artery, and also the obturator vein. So this is the obturator vein. So if you see here, this is obturator artery, obturator vein, and obturator nerve, and also obturator bone. Okay. So you can see here. Yes. You can see here. Okay. See this obturator canal, through which this obturator artery, obturator vein, and obturator nerve is passing, and it is exiting out here. Okay, this obturator nerve is coming all the way down, and it is supplying the medial aspect of the thigh muscles. Okay, so here you have the adductor muscles in the medial aspect of the thigh. These are all the adductor muscles. Okay, which is innervated by this obturator nerve. Okay, adductor magnus, adductor longus, adductor brevis, and the gracilis. All these are the medial thigh muscles innervated by this obturator nerve, which is giving the motor fibers. Okay, nerve you got here is the. Okay, these are all the important nerves. Okay, these are all the important nerves of the uh, lumbar plexus. These are the important nerves of the lumbar plexus. Okay, next we will go into the sacral plexus, which starts from L5, nerve root, Okay, this is the L5 nerve root. Let me put it for you. This is the L5 nerve root. Okay, L5 nerve root. S1 nerve root, then S2, S3, and also the S4. Okay. So these are the nerve root of the sacral plexus: L5, S1, S2, S3, S4. The important thing you have to understand here is, you see, this is the intervertebral foramen. This is the intervertebral foramen. This is the intervertebral foramen of the L5S1. This is a sacral. This is a lumbar thigh vertebra. Okay. This is the lumbar thigh vertebra. and this is the sacral 1 vertebra. This is S1 vertebra. So if you see here, 5, S1, S2, S3, S4 and S5 vertebra. Okay, the intervertebral foramen here for L5 S1 vertebra is present here. Okay, whereas the intervertebral foramen between S1 and S2 vertebra is here. S2, S3 vertebra is here. S3, S4 vertebra is here. So through this foramen only the respective nerve is exiting out. Okay, so what happens when there is disc damage of L5 S1? It can compress the L5 S1 nerve root, but here there is no chances of nerve root compression. There is no chances of nerve root compression, but still the nerve gives some branches for the sacral nerves. Okay, sciatic nerve. So we will discuss that. I will remove this femur bone so that you will have a better view. You will have a better. Okay. Now if you look at these nerves here, if you look at the nerves here, okay. So the main nerve. So let's go to the branches of nerves of these regions. So what you see here is the important nerves are the inferior gluteal nerve and the superior gluteal nerve of L5S1. Okay, so this is the superior gluteal nerve. This is the superior nerve, and it's a posterior ramal branch. This is a superior gluteal nerve. It is posterior ramal branch that is supplying the gluteus minimus and the gluteus medius muscle. So the gluteus muscles are located here. The gluteus muscles are located here. The gluteus muscles are located here. This is a gluteus maximus muscle innervated by the inferior gluteal nerve, and these are the gluteus medius. Okay, that is innervated by the superior gluteal nerve. Okay, see here. What you can see here is the superior gluteal nerve that is innervating the superior gluteus muscle. Okay, so this is how the gluteus muscle is getting innervation by gluteus. So now if you look at the superior gluteal nerve that is innervating the gluteus muscle, so this is the inferior gluteal nerve. This is also a branch from the sacral vertebra. This is also a branch from the sacral vertebra. You can see the branch is starting here, and the muscle gets innervated here. So okay, so next nerve is the sciatic nerve. The sciatic nerve is said to be one of the longest of all the nerves. The sciatic nerve is said to be one of the longest of all nerves. Okay, so this sciatic nerve, it starts from the root of L4, L5 is L5, S2 and S3. Okay, it starts from the root of L5, S1, S2 and S3, and this nerve is formed in the anterior aspect in the pelvic cavity. This nerve is formed in the anterior aspect of the pelvic cavity, and here what you see here is a greater sciatic notch. Okay, greater sciatic notch of the iliac bone, and this nerve passes through the greater sciatic notch and it descends posteriorly. It is descending posteriorly and going all the way down in the posterior aspect of the thigh. Okay, you know this gluteal region is the important region for uh, intramuscular injection site. This gluteal region is important region for intramuscular injection. Gluteal region and divided into four divisions. Okay, divided into four divisions. Okay, so now you have to select this upper outer quadrant for intramuscular injection. You are going to select this upper outer quadrant for intramuscular injection. Okay, so what will happen if you give the intramuscular injection other side is, suppose if I remove this gluteus, you see there are chances of this damage of the sciatic nerve. The sciatic nerve is passing exactly in the center of the gluteus muscle. See, for adult the muscle is bulky and there are less chance for the nerve to injure the sciatic nerve. But whereas for newborn baby, if you are giving injection, if you are for newborn baby, if you are giving injection, you have to select this upper outer quadrant and you have to save sciatic nerve. Okay, suppose in case if you puncture the sciatic nerve and damage it, okay, then this sciatic nerve is supplying all the muscles of the leg. Okay, so what happens if this nerve is damaged? All the muscles of this region will not work. If the nerve is not working, muscle doesn't work. If the muscle doesn't work, the skeletal growth is disturbed. So whole life the baby is crippled with one leg. We call it as the sciatic nerve injury. The sciatic nerve injury. Okay. So this is the clinical importance you have to understand here. There is a muscle that can compress the sciatic nerve. Okay, okay. This is the sacral vertebra. This is the sacral vertebra, and this is the greater trochanter of the femur. This point is the greater trochanter of the femur. This point is the greater trochanter of the femur. Okay. So in between these 2 points, there is a muscle called piriformis. Okay, there is a muscle called piriformis. Just underneath you have this sciatic nerve. So what happens whenever there is spasm of this piriformis muscle, it can lead to compression of this sciatic nerve. You all very well know wherever the nerve is compressed, there is radiating pain in all the place where the nerve is distributing. Suppose if there is compression here, there is radiating pain area up to the tip of the great toe. Okay, the patient feels the radiating pain present in the posterior aspect of the thigh. You see, because the sciatic nerve is passing in the posterior aspect of the thigh, and then it is dividing in the posterior aspect of the knee, and it is distributing to all these lower limb areas. Okay, so there is radiating pain in the posterior aspect of the thigh. That means what? There is some nerve root irritation. We call it as sciatica. We call the condition as sciatica. Okay, so this is called the, if the piriformis muscle compresses sciatic nerve here, we call the condition as piriformis syndrome. Okay, we call the condition as piriformis syndrome. Okay, coming back here, if you look at this femur, if you look at in posterior aspect there are lines. This line is called as the linea aspera. This line is called as linea aspera. This linea aspera is a rough line that is dividing into the medial line and the lateral line. Okay, that is dividing into medial line and the lateral line. Along with this line, this sciatic nerve is dividing into two branches. One is the tibial nerve and other is the common fibular nerve. Okay, in some book they call it the common fibular nerve as the lateral popliteal nerve or the common peroneal nerve. Okay, likewise the tibial nerve is also called as the medial popliteal nerve. It is called as the medial popliteal nerve. Okay, so if you look here, if you look at this medial popliteal nerve and the lateral popliteal nerve, they divide in this region and they pass in the popliteal fossa. What is the popliteal fossa? So this is the knee joint, the pit in the posterior aspect of the knee. We call it as the popliteal fossa. The pit in the posterior aspect of the knee, we call it as the popliteal fossa. So coming here, this tibial nerve is passing through the intercondylar notch and it is supplying the muscles that is present in the calf region. This region is called as a calf region and these are the calf muscles. Okay, these are the calf muscles. We have this gastrocnemius and the soleus. We have the gastrocnemius and the soleus. This is a tibial nerve that is passing in the posterior aspect of the leg and it is innervating all the muscles of the posterior aspect of the leg. Okay, then this tibial nerve, it comes down all the way, it comes down all the way and it is coming to the medial aspect of the leg and it is giving a branch here. Okay, so this branch is called as a medial plantar nerve and another branch that is called as a lateral plantar nerve. So these two nerves are supplying the muscles of the foot. Okay, these two, the medial plantar nerve and the supplying the muscles of the foot. You have a lot of muscles, small muscles that is maintaining the arch of the foot here. Okay, if this nerve is injured in this level, then the foot arch will collapse due to paralysis of those muscles. Okay, so then coming to the lateral popliteal nerve, that is the fibular nerve. The fibular nerve goes in the lateral direction. The fibular nerve, it goes in the lateral direction. Okay, and it comes all the way down to the neck of the fibula. This is the fibula and this is the neck of the fibula. This is the neck of the fibula. This nerve is more superficial in this region. This nerve is more superficial in this region. Okay. In fact, the fibular nerve, this is the main nerve that is more superficial in the neck of the fibula. So if there is any direct flow, direct blow or direct hit in this neck of the fibula, it can lead to damage of this fibular nerve and this fibular nerve is supplying the muscles of the anterior lateral aspect of the leg. Okay, so here these muscles that is present here are the anterior lateral. Okay, this is the anterior aspect. Okay, and this is lateral aspect. All these muscles are innervated by this fibular nerve. So when there is paralysis of this damage of this nerve in the neck of the fibula, because it's more superficial and a direct hit by a thick stick can also damage this fibular nerve. So this is what happens. A person cannot do dorsiflexion. So this is a dorsiflexion. Okay, the person cannot do, if these muscles are paralyzed, he cannot do the dorsiflexion. So what happens? The foot will drop. The foot will drop. So when the foot drops, he cannot keep the heel straight during the gait. Okay, I mean when walking, he cannot keep the heel in the floor. So he has to slap the foot and walk. So that condition is called as foot drop deformity due to damage to this lateral popliteal nerve, that is a fibular nerve that is supplying all the muscles in the anterior lateral aspect of the leg. Okay, that is the muscles of the anterior lateral aspect of the leg. So if you look at this fibular nerve, it is also giving the cutaneous distribution, sensory nerve distribution. the sensory and lateral sural nerve. Okay, so this lateral sural nerve is giving the innervation, sensory innervation to the lateral aspect of the leg. See, you have to understand this dermatomal pattern. You have to understand this dermatomal pattern. Okay, this is the lateral sural nerve dermatomal pattern, and this L5, the S1 is the lateral sural nerve dermatomal pattern. And you know what? If L5 disc is compressing the sciatic nerve root, you can feel the pain up to the tip of the great toe. Likewise, if the L4 nerve root is compressing, you can also feel the compressing nerve root. You can also feel the pain to the tip of the great toe. Okay, and as I told you, dermatomal innervation, all you have to understand is the sciatic nerve is the longest of all the nerves. Okay, it is distributing all the way up to the tip of the great toe from the lumbar region. Okay, so if there is any damage to this nerve root, if there is any compression to this nerve root, the pain is radiating all the way down in the posterior aspect of the thigh, because the nerve is passing the posterior aspect of the thigh then to the leg. Okay, so you can do the straight leg raising test and find out the issues. Okay, next, the posterior femoral cutaneous nerve is there. Okay, and also now we have to, from L1 to S4, we can call it as lumbosacral plexus. L1 to L4 is lumbar plexus. L5 to S4 is sacral plexus, but L lumbar 1 nerve to sacral S4 nerves, collectively we call it as lumbosacral plexus. Okay, now we have the coccygeal plexus, that is S5 and C1. Okay, so there are important nerves in this region. So if you look here, there are important nerve in this region. If you look in this place, you have to identify nerve. Okay, that's the important nerve in this region. Okay, so let me show you that. This is the pudendal nerve. And if you look at those branches, this pudendal nerve is starting at the S5 and the C1 nerve root, and it is supplying all the way to the pelvic diaphragm muscles and also the genital region. So we will look into the branches of this pudendal nerve. Okay, we will look into the branches of the pudendal nerve. So you have this pudendal nerve. Okay, now the first branch of the pudendal nerve is the inferior nerve, is the anaphyl. Then the next branch of the pudendal nerve is perineal nerve, that is also supplying the perineal region and also the muscles of the perineal region. And here, if you look at the terminal branch of the pudendal nerve, it is supplying this. Okay, wait. Okay. These are the dorsal nerve of the penis. Okay, so same nerve, if you see the origin path, this, there is difference between the pudendal nerve for male and the female. Okay, this nerve is distributing in the dorsal aspect of the penis. In the dorsal aspect of the penis. Okay, this protein sac. branch of the superficial peroneal nerve. This is the branch of the superficial peroneal nerve. Okay. Whereas if you see the same thing in the female pelvis, if you see the nerve in the female pelvis, this pudendal nerve is ending here. Okay. So this is the okay. This is the pudendal nerve in the female. This is the pudendal nerve in the female. It is having the same nerve root like the male, but it takes a different name here. Okay, one branch is the inferior anal nerve and the perineal nerve, and then the nerve to the clitoris. So the clitoris is compared to the glans penis of the male. Okay, so in the male, this branch is taking the name as the penile nerve. Okay, dorsal nerve of the penis, but in female it is taking the name as the dorsal nerve of the clitoris. It is taking the name as the dorsal nerve of the clitoris. If you look at the connective tissue fascia, if you look at the connective tissue here, okay, so here, this point, if you look at this point, see this sheath is called as the inferior pelvic diaphragm fascia. Okay, and this sheath is called as Pudendal Canal. This is the Pudendal Canal. You can see this is a Pudendal Canal. Okay. It's also called as the Alcock's Canal. Okay, through which the pudendal nerve is coming. It is a modification of the apparatus fascia. You see, you can see here. This is, I think, this green area. This is Alcock's Canal. Along with this pudendal nerve, the pudendal artery is also coming. The pudendal artery is also coming, and the pudendal is pudendal nerve, pudendal artery, and the pudendal vein. You see, this is the apparatus membrane. This apparatus fascia, membrane fascia, is forming a tubular structure through which the pudendal vein, artery, and the pudendal nerve is coming. So this is the pudendal vein, this is the pudendal artery, and this is the pudendal branch of pudendal nerve. Okay, and this canal is called as the Alcock's Canal. So what is the clinical importance of this Alcock's Canal is, suppose I am an athlete who is riding a bicycle. So what happens when you ride a bicycle, the inferior aspect of the pelvis will, you will see the pelvis. Okay. So what happened here, this is the pelvic outlet, and this point is called as the, okay, this is the ischial tuberosity where you sit. Let me draw. This is the ischial tuberosity where you sit. Ischial tuberosity, and this is the os pubis joint, and this is the tip of the coccyx. Tip of the coccyx. What you have to do is, you have to draw one imaginary line between the os pubis and the ischial tuberosity. Then draw one imaginary line to the tip of the coccyx to this ischial tuberosity. Okay, now draw one imaginary line. Draw one imaginary line between these 2 points, 2 ischial tuberosity. So you can see one triangle here. This triangle is called as urogenital triangle. Okay, this triangle is called as the urogenital triangle. And now what you see is another triangle here. This triangle is called as the anal triangle. This triangle is called as the anal triangle. This triangle is called as anal triangle. Okay, so there are two. How you form this triangle? Ischial tuberosity, os pubis joint, and the tip of the coccyx. Draw imaginary line between these 4 points and draw a transverse imaginary line. So this forms the urogenital triangle, and this triangle is the anal triangle. Okay, so what you have to understand, in the anal triangle you have the opening of this anal ring, whereas in the urogenital triangle you have the opening of the birth canal. You have the opening of the birth canal. You have the opening of this birth canal as well as the urethral opening. This is the urethral opening. Okay, so this landmark is very important when you do episiotomy during the time of labor. There is in the widening of this birth canal. If the head circumference is too big, there are chances for tearing that is taking place in this direction or in this direction, that will damage the circular muscles and that leads to permanent incontinence of fecal matter, or there is incontinence of urine. So to be safe, you have to cut in this direction or in this direction to preserve the circular muscles of the anal ring or the urethra. Okay, so if you look at the innervation here, this in branches of pudendal nerve is coming in the lateral aspect. So this is a pudendal nerve. This is a pudendal nerve branch, that is a pudendal nerve. Okay, so here, so what happens here? When a person is riding a bicycle, he sits here, and there are chances of compression of this pudendal nerve branch, and that is leading to perineal pain. Okay, that is inferior pelvic diaphragm pain. Okay, so the pelvic diaphragm muscles are innervated by these nerves. Okay, so this pelvic diaphragm is the coccygeal muscle and the levator ani muscles, and this is the levator ani and the coccygeal muscle. Okay, so that we will discuss that in myology, no problem. So just know how the nerve is flowing in this region. Okay, fine. So by this we are completing the spinal nerves. By this we are completing the spinal nerves. Yes, coming to the short review of the nerves that we discussed now, the important nerve in the lumbar plexus is this femoral nerve and the obturator nerve. Femoral nerve that is supplying the anterior thigh muscles, and the obturator nerve that is supplying the medial thigh muscles. Then in the sacral plexus, the important nerve is the sciatic. Okay, that is very tibial and common fibular nerve, and also the nerve that is supplying the gluteal region. And you can see the various plexus, the rami that is coming out. So I think this will give you a better understanding. Okay, here you see this is the L1 nerve root, L2 nerve root, L3 nerve root, L4 nerve root forming the lumbar plexus. L5, S1, S2, S3, S4 forming the sacral plexus. This L1 till S4 we collectively call it as lumbosacral plexus. Okay, then this is the coccygeal plexus, where the S1, S5 and the C1 nerve root forms these nerves. So in lumbar plexus, the important nerve, if you see, is the lateral cutaneous branch, iliohypogastric and ilioinguinal nerve, genitofemoral nerve, and the lateral femoral cutaneous nerve of the thigh, and also the femoral and obturator nerve. Okay, then in the sacral plexus, the important nerves are the superior and inferior gluteal nerve and the sciatic nerve, and also posterior femoral cutaneous nerve. Okay. Likewise, in the coccygeal plexus, the pudendal nerve is an important nerve, and also their branches. the coccygeal nerve and the anococcygeal nerve. Okay, these are the important nerves that you have to know, and I think I have showed you these nerves in your models, in the models. Okay, coming to the dermatome. Okay, this is something you have to understand about the cutaneous innervation to the skin. Okay, so if you look, there are a lot of dermatomal map that you need to understand. So in this, there is a common law called Hilton's law, which says that any nerves in a muscle that produces movement at a joint also innervates the joint and the skin over the joint area. This is according to the Hilton's law. So let us go and see what is the dermatomal map that you have to understand. So as a layman, clinically, if you see, uh, there are patients who come and complain the pain that is distributing in the hand and the upper limb or in the lower limb. So if you look at the skin, this is a complete skin of the body. Okay, and if you look at the dermatomal map, this is the complete map you can see. Okay, so what I would like to say is, let's discuss the face. Let's discuss the dermatomal map from the face. Okay, if you see here, the V1, V2, V3 is the branch of the trigeminal nerve. Okay, you know the trigeminal nerve, that is a thickest cranial nerve that is supplying the sensory supply to the face. Suppose if there is a pinprick here through the uh, V1, that is the ophthalmic branch of trigeminal nerve, the sensory information is going to the brain. Okay. Likewise, if there is pinprick in this region, then C3 nerve root takes the pain impulse to the brain. Whereas if there is pinprick in this region, okay, or if you are giving intramuscular injection region, in this region, the C6 nerve root is taking the pain impulse towards the brain. Okay. So what you have to understand here is, okay, you see this C6 nerve root, that is a nerve root. If the disc is compressing the C6 nerve root here, so what happens? There is radiating pain the patient can experience in all this place up to the only in the thumb region. Okay, whereas if the C7 nerve root is compressing the disc, then the patient experiences pain, radiating pain in the posterior aspect of the arm and also in the first two fingers. Okay, if there is nerve root compression of C8, if the C8 disc is compressing the C8 nerve root, then the patient experiences radiating pain in this posterior aspect of the hand, that is the little and the ring finger. Okay, likewise, if there is T1 nerve root, there is radiating pain in this region. Okay, so likewise, the disc compression in the thoracic vertebra is very rare unless if there is a fracture like that. Then the respective nerve will conduct the radiating pain along the nerve root. Okay, and moreover, the L5 disc, when this L5 disc is compressing the nerve in this region, in this region, okay, what happens? This L5 nerve is giving the cutaneous supply, that is the skin supply to this region and also to the up to tip of great toe. So if the radiating pain is in this region, then you can suspect, yes, there may be some disc issue in the L5 region. Or if the radiating pain is present in the medial aspect of the leg. So that's why in clinical examination you have to see the difference between the right leg and the left leg and the medial side or the lateral side. Okay, you have to do the sensory examinations so to find out what kind of pain and in which nerve distribution the pain is radiating. So this dermatomal map is very important for you to work in the clinic area. No need of X-ray or MRI, directly by clinical examination, by doing straight leg raising test, you can say if there is a patient that is having the nerve root compression or not. Okay, as I told you, the athletes, when there is compression in the nerve root, the pudendal nerve, then the S4 S3 nerve area. This is the perineal area where there is severe amount of pain. Okay, so this map, dermatomal map, is very helpful for you to assess the nerve root irritation in the vertebral level. Okay, so as a gentle layman, in order to keep the nerve root healthy, you have to strengthen this muscles, the paraspinal muscles that is present in the adjacent areas of the vertebra. Okay, imagine these are all the paraspinal muscles. All these muscles has to be strengthened so that it maintains the good proper alignment of the vertebra under this. Okay, so make sure that you advise the patient to take care of the curvature. In osteology, I will teach the importance of all these things. Okay. Now we are in neuro. I don't want to deviate the topic. Well, these are the some of the important clinical aspect you have to understand about the dermatomal nervation. Okay. Coming back to the slide. Coming back to the slide, we have seen the dermatomal innervation. Then we will now go into the referred pain. Okay, well, pain, it's really a good sign for you to know that there is some pathology that is taking place in the body. Okay, so the referred pain is perceived at the location other than the site of the painful stimulus origin. As I told you, when the L4 nerve root is compressing the nerve root, the nerve distribution is having the referred pain. It's called a radiating pain. Okay. Likewise, for the visceral organs, okay, that respective sympathetic nerve innervating to that organ is also distributing to the other organs. We will see that maps. Just know that referred pain is a pain perceived at a location other than the site of the painful stimulus. Okay. Suppose if there is pain in the heart, there is radiating towards the hand and the jaw area. Okay, left jaw area. We will see why. Okay. The nociceptors from several locations converge on a single tract in the spinal cord. The pain signals from the skin are more common than pain from the internal organs. Brain-associated activation of pathway pain on the skin also occurs with cardiac ischemia. So if you look at this picture, you will be able to understand. Just watch carefully. The heart is in the left side. Okay. So when there is myocardial ischemia, the patient complains there is radiating pain to the left jaw as well as the left upper limb up to this region. The shoulder as well as the medial aspect of the hand. Okay, so whenever there is heart attack, the patient experiences severe amount of pain to left jaw and also radiating pain to the left shoulder. You can ask why. Why? Because the sympathetic chains that is innervating the heart is distributed to these regions. That's why there is radiating pain. Likewise, if there is any damage in the liver or any inflammation in the liver, the patient experiences pain in the apex area of the lung, that is in the right side upper chest region as well as on the location of the liver. Okay. Likewise, if there is any gallbladder inflammation or gallstone formation, then there is pain in the gallbladder location area as well as in the right shoulder region. Okay. And if there is pain in the pancreas, this is the location of the pancreas. The posterior aspect of the body has same epigastric region as well as the posterior uh, of the T12 vertebral region has severe amount of pain. Okay, whereas if there is pain in the stomach, there is anterior epigastric pain only. Okay, due to some peptic ulcer disease or something like that. Okay, and coming to the kidneys. Okay, kidney is located in the posterior lumbar region, but all this area has severe amount of pain when there is any renal stone formation. When there is renal stone formation, and for the appendix, this is located in the right leg fossa. The pain is present in this region only. Okay, so these are all the simple referred pain you need to understand when there is any damage to these visceral organs, because the sympathetic nerve that is supplying in this region also supplying in the associate region where you can see the color maps. Okay, so generally patients coming with the heart attack, they experience the pain in the left jaw region as well as in the left shoulder and the upper limb radiating pain will be present. Okay, this is what you have to understand about the referred pain. Okay, this is what you have to understand about the referred pain. So I think by this we will complete this peripheral nerves.